I think it's time. Shall we start? So, welcome to the Symposium 4A, taking the pulse of multisource feedback, perspectives, and lessons learned across the globe. And there'll be 3 presenters and 1 moderator. All are going to be online. Andrew is from Canada, and he's moderating the session virtually. However, I'll be here to coordinate the questions and all that if there's a needs. So over to you, Andre.
Thank you very much. I have the easy role in this particular symposium in that what I'll be doing is really setting the stage for what will be 3 excellent presentations which will follow, and we hope a rich discussion afterwards. If we could go to the next slide, please. I think there's a growing recognition on the part of many, not only in medicine, but many professions, that what we call soft skills play an increasingly important role in professional success and also in educational success. That's true not only in medicine, but in a whole host of professions. Now, I've put the word soft skills in quotation marks because there's still, unfortunately, somewhat of a pejorative connotation that's associated with that term, which is unfortunate. When we talk about medicine in particular, we're not talking about engineering. And in that, I mean, not everything has a technical solution. In fact, there's mounting evidence to indicate that things such as compassion can really have positive impacts on patient outcomes, whether it be pain, anxiety, healing rates, etc. And I list 1 reference here. There's also evidence suggesting that empathetic surgeons, for example, have improved healthcare outcomes, again with the reference added. Next slide, please. Also, if we look at 3 of the big competency-based frameworks currently in medical education, first of all, it's remarkable to see how comparable they are. They're virtually identical, though different verbiage is used. It's also interesting to note that the vast majority of the competencies that are listed are not in the biomedical expert sphere, but rather the humanistic, interpersonal, etc. spheres. So clearly there's a need to also assess those particular competencies in addition to biomedical expertise. Next slide, please. In an effort to help us to assess some of these non-medical expert competencies, a number of toolboxes have been proposed. I'm only listing 2 here as examples, one from Canada, the other from the United States. And in most of these particular toolboxes, multi-source feedback, or MSF, is suggested as 1 tool or 1 process to be included to assess several of the competencies that were shown in the framework, such as professionalism, interpersonal and communication skills, system-based practice, and so forth. Next slide, please. So the aim of this particular symposium is really to allow 3 presenters to provide a number of perspectives of lessons on the lessons learned in implementing MSF programs. And we'll hear from presenters in Canada, Australia, the Netherlands, and we really hope that this will foster interesting discussion with all of you that are present in the room or online. Next slide, please. The presenters, I'm sure, will introduce themselves, but I do just quickly want to mention that we have 3 excellent speakers today. One of my colleagues, Dr. Claire Touchy from the Medical Council of Canada, Professor Kitchener from the School of Medicine and Public Health, Newcastle, Australia, and Professor Tenkat from Utrecht in the Netherlands. So without further ado, I'm going to turn things over to Claire for her presentation.
Well, thank you everyone for allowing me to present from very late at night in Ottawa, Canada, where it is snowy and cold and expecting some rain tomorrow. Today what I will do is talk to you about our multi-source feedback, which is called MCC 360, which is a program approach. If I could have the next slide, please. I do wish to acknowledge my colleagues who have worked with me on this, Dr. Marguerite Roy and Dr. Andrea Gottsman, both from the the MCC 360 team, and Dr. Nikki Kane, who is at the College of Physicians and Surgeons of Alberta, with whom we have done this project. Next slide, please. So MCC 360 is actually a national multi-source feedback program to evaluate physicians' workplace performance. Its purpose is purely formative. It's really designed for quality improvement and not designed for quality assurance. Physicians get insight into their performance specifically in 3 of our CanMed's roles, that of communicator, collaborator, and professional. It was decided not to include the medical expert role in our multi-source feedback, as we felt there were other assessment modalities which were more appropriate for this. And the fact that from previous data, the communicator, collaborator, and professional role were all critically related to patient safety. Could I have the next slide, please? The MCC 360 provides physicians with meaningful and actionable feedback, both qualitative and quantitative, from 4 rater groups, namely from self, patient, non-physician coworker, and physician colleagues. Each survey has a number of items followed by 2 specific questions. What is the one thing a physician does well, and what is one thing that this physician could do better are the questions that are asked. Next slide, please. How does it work? Well, there's 3 components. There's the surveys that need to be completed by the respondent groups. We ask that there be 8 physician colleagues, 8 non-physician coworkers, and 25 patients that respond for us to deem it complete, and the physician does a self-survey. Then we produce a report that has both quantitative data as well as qualitative feedback, and the average, the physician gets an average of between 25 and 35 qualitative comments in addition to all the ratings. Then the participant reviews the report with a trained facilitator and builds a personal action plan, which we feel leads to practice, specifically to practice improvement. Next slide. So what's different from our previous versions? First of all, the non-expert based roles evaluation. We always had in the past a physician expert role, but we've taken that out as we felt that this was better suited for purpose. We do have those narrative comments, and this is based, this is evidence informed based on the work of Jocelyn Lockyer. The report has both quantitative and qualitative comments. It's reference to self and not norm reference to a group, which means that you compare yourself to what you think you are like, and not comparing yourself to a group that's already way above average when we look at how they are scored. The facilitated feedback is done using the R2C2 model with a trained assessor, and this is based on the work of Joan Sargent and her colleagues. The physicians were all asked to do 3 action plans, and there is a 6-month follow-up on the action plan to see what's been started. And right now, we've gone live with this after a 2-year period of pilot, and it is not only available for businesses to use, such as colleges or hospitals, but it's also available for individual use. Next slide. So I'm going to talk about 3 of our areas of work to date. The next slide, please. So of course, we've done some validity work using both the qualitative and the quantitative data, and we've done both quantitative and qualitative data analysis. And what we found is that the survey ratings really provide a way to structure and prime the comments. And then the comments are used to provide specificity and context. And that is used for the facilitated feedback discussion with the trained assessor, and it allows to explore and externalize the meaning of the report. The candidates or the participants can reflect and either accept or reject what has been suggested, and then they can select of the feedback what they're going to use and put into their action plan. The action plan provides a focus and structure, as well as commitment to action so that they can change. And our survey reports at 6 months do show that they have changed, which I'll show in the next slide. Next slide, please. So I'm going to show two short studies that we are in the midst of doing right now. One is on the receptivity of the facilitated feedback and how the CanMed's roles that they focus on in their action plan. So based on 139 reports, we've had 719 participants as part of the pilot study, but we have linked reports for 139 participants, and according to the facilitators, 96% of the participants were receptive to their feedback versus 4% that were not. Of the 96%, 40% of their action plan focused on the communicator role versus the ones that were not very receptive to their plan, which mostly focused on the professional role. Next slide, please. I'll walk you through this slightly complex plan, which was really to look at what were the drivers to lead to quality improvement. And one of the things that we looked at were whether the driver was the physician themselves based on the report, whether it was driven by the facilitator, or whether or not the report were co-created. We also wanted to look at the actions taken. So did they ignore the data? Did they reflect on the data? Or did they use the data to formulate the plan? What type of change did they put into place? Was it a small change, such what we would call an accommodation based on our model, which was fairly simple, or was it an adjustment, which was more small to moderate, but where it would take more time? And finally, the results, did they institute that change? Is it in progress or is it complete? And if you can show the next slide, please. So what we did find is that we've to date reviewed 20 completed files of those 139 data files that we have, just to see what we would get as a preliminary look. And of those, 11 were co-created with the facilitator and the physician. And of those co-creations, 64% of the action plan are actually complete. If you look at the action taken, 47 out of 55 plans, you have to remember that many of the plans, they actually came up with 3 action plans each. And 47 out of the 55 plans that we reviewed used the MCC 360 data, so 85% of those. Of the plans, 70, those that did not, that ignored the data, all wanted to do very large changes. So they weren't looking at the feedback directly, they wanted to institute other change. Of those that have looked at change, 9 out of the 20 have completed their plans. So you can see that using this report, they're actually being very mindful and completing their plans. Next slide. Another study that we've embarked upon, which is really interesting, is using automated text summarization. You can imagine that if we had 719 participants, all of them having approximately 25 comments, qualitative comments, that comes out to about 18,000 comments. That's a lot for humans to review. We've actually reviewed 325 files to date and came up with themes using thematic analysis or descriptive qualitative analysis. However, with recent advances in computer technology, namely machine learning and natural language processing, there's really exciting potential to help the qualitative researchers do their job. So one of our researchers used NLP and machine learning to cluster text documents into different topics based on the word distribution, and they identified quotes that are really representative for each topics. And then we compared what we got as qualitative researchers versus what the machine received. And I give you one example here of the theme that was work-life balance. And the two quotes are, over his career, he could have worked less, paid more attention to his personal health and well-being. While the second quote says, Dr. X has dedicated her life to the practice of medicine, and especially in her earlier years in practice, I felt that Dr. X should have tried to find a better work-life balance. And there were 171 such comments that fell into that theme. We were able to identify 26 themes by doing this. It took us weeks to months to actually do the descriptive qualitative analysis. After data cleaning, it took the machine an overnight to be able to find those 26 clusters, which we were able to theme together. Next slide, please. So what are our lessons learned? Next slide. So I think that what we've learned is that it's really not just about the tool, it's really about the entire process. So from doing the survey to setting out your action plans and being able to do quality improvement. The second thing is that we need to automate. If we're using qualitative data in addition to quantitative data, it is burdensome to be able to work with this, to be able to come up with themes, even in potentially for the reports, it's very helpful. Managing expectations, our MSF in the past was used for quality assurance, and this is really about quality improvement, and it has taken us a lot of time to teach our stakeholders that this is what it's about. And finally, we need to do program evaluation to ensure that the users are actually getting what they expect. Next slide. Just a little bit on our future directions. Next slide. And you can skip that and go on to the next slide. So we've done this pilot project using family physicians, and we are now gathering validity evidence outside of family physician. We are looking at 500 physicians who are in specialty practice, and hopefully we will get as promising results as with family practice. We're also looking at innovative survey report offerings, which include clinician teacher surveys. For years, we have found that clinician teachers do not get good feedback from their learners. It's often a negotiation almost. This would provide a means of doing so, and we're going to look at innovative ways of doing this. Group-based surveys, so for group practices, and we're entering a project with that. And finally, team-based surveys. We're also going to study rater bias and different survey types, looking at forced choice. Right now, our surveys are Likert-based, and Andre's team would really like to look at forced choice. So we're entering that, as well as the possibility of pre-choosing raters, as that has been something in the literature that has been discussed. So I'm going to end here and let Kichu go next. Thank you very much.
Thank you very much, Claire. The next speaker is Prof. Kichu Balakrishnan.
Yeah, are you?
Yep.
I have my slides, please. Yeah.
Yeah, it's there, I think.
Okay, thank you very much. So Claire has set the scene. So I'm going to talk about our experience with assessment of international medical graduates and the multi-source feedback. Can I have the next slide, please? Okay. So in Australia, all overseas trained graduates, I think I need to, my camera on? No. Nick, I can't see.
Please go ahead. Please go ahead.
Okay.
We can hear you. Yeah.
Okay. In Australia, all overseas trained doctors will have to do an AMC, or Australian Medical Council exam, to qualify to work in Australia. We have a shortage of doctors in Australia. Something like 25 to 30% of our doctors are overseas trained. If they come from countries outside United Kingdom, United States and Canada, they have to do a written examination followed by clinical examination, which is an OSCE format exam. The OSCE exam lasts for about 3 hours or so. And we also employ a lot of doctors who are working on a temporary visa and registration while they're waiting for the clinical examination. So we decided if they're working as junior doctors on a temporary registration, why don't we assess them when they are working as junior doctors rather than the OSCE exam? So in 2011, in Newcastle, we introduced workplace-based assessment. So we use mini CX, which are blueprinted, case-based discussions, and multi-source feedback. I'm only going to talk about multi-source feedback today. Why did we do the workplace-based assessment? Because all doctors who come to work in Australia, it's a big cultural shift for them. They are working in a different culture, different health system. So I think for the patients and the society, I think their performance is more important than their competence. So again, we believe workplace-based assessment and performance assessment is assessment for learning, not assessment of learning. So in our program, we have used 6 multi-source feedback, 3 from medical colleagues and 3 from non-medical colleagues in month 1, followed by, at the end of the program in month 6, another set of 6 multi-source feedback rating, again 3 medical and 3 non-medical colleagues. And if they have issues identified during the first set of 360 assessment or multi-source feedback, a committee of interdisciplinary people spoke to them and put in some remediation. And at the end of 6 months, we have realized and we have identified, and the feedback from the candidates too, were that these people have improved tremendously over a period of 6 months. So constructive feedback helped them to improve their performance. Over the last 10 years or so, in Newcastle, which is our center, we have assessed over 250 international doctors. And all failures in workplace-based assessment were related to failure in multi-source feedback. So that's a very good assessment tool. Can I have the next slide, please? So since we introduced this, there are 10 providers or 10 centers in Australia doing workplace-based assessment. All providers use multi-source feedback. Some of them use up to 16 forms. Some of the programs last for 12 months. Our program in Newcastle, we do over a period of 6 months. so far in Australia, we have assessed over 500 international doctors using the WBA and multi-source feedback. We have some issues with the forms because the original forms are designed to assess all sort of doctors. We want to fine-tune the program and the evaluation form, rating sheet, to assess the international doctors. So we are working on this as we speak. Next slide, please. Andre mentioned the soft skills. In any exam medical assessment, we tend to concentrate on so-called hard skills, which is medical knowledge alone. Whereas we realize now the intrinsic roles or the so-called soft skills are equally, if not more important. For example, we need to assess the doctors on the communication skills because we know some of the overseas schools do not teach communication skills. In 2020, every doctor will have to work in a team. So these skills are usually not taught or assessed in most of the medical schools. So we need to have a new way of assessing doctors. And we also found from our qualitative studies, at the end of the 6 months, the doctors reported they were very happy with the assessment. They were very keen to know what their colleagues thought about it. And we also found from feedback from the assessors and supervisors, the 360-degree assessment helped them to improve their performance. Next slide, please. Could I have the next slide, please? So the question is, do soft skills save life? Are they really, really soft? And is the practice of medicine just only about knowledge and scholarship? I refer you to a very good article in MedEd published on this topic in 2019. And I think the title is How to Convince Clinicians That Soft Skills Save Lives. A very good reference. Next slide, please. The patient outcome. We know if we train medical people to work in a team, it can reduce the annual mortality. I myself work in an orthogeriatric team, and we know people working together in an orthogeriatric team will reduce the waiting time for surgery. Patients are optimally prepared for surgery, then have fewer infections, and length of stay is reduced. We also know in intensive care unit, a multidisciplinary care can provide better quality of care and reduction in mortality. So these skills are not then soft. Next slide, please. Communication. Again, we know by improving communication, people have improved glycemic control in diabetic patients. When patients and doctors work together, they improve medication compliance. There are studies showing that if the patients are happy with the inpatient care and if they're satisfied with the inpatient care, unplanned readmission can be reduced. We have done some work on advanced care planning in hospitals, and again, there's another reference there. It reduces stress for families and even medical people if there's advanced care planning written for patients. So all these soft skills are really, really important. Next slide, please. What about health advocacy? Doctors should be doing more of this. When we see a patient and prescribe exercise as the treatment, it will lead to reduction in blood pressure and reduction in BMI. If doctors work with patients and give strong messages, 1 in 4 people approximately will reduce smoking. and then it will reduce mortality. So again, health advocacy is not a soft skill, it's a hard skill. What about leadership? We know when doctors provide antimicrobial stewardship, there's a 50% reduction in clostridial difficile infections. We also know that in team working, in stroke units, can improve patient outcome. So in summary, all these soft skills are important, and we should be teaching and we should be assessing using these skills. And the only way to assess these skills will be doing multi-source feedback. The same thing with professional behavior. When doctors don't follow up test results, we can miss dangerous conditions like cancer. We also know, I think Andre mentioned this before, empathy can improve metabolic complications. Again, there are studies showing that what doctors look like, what they wear, is very impressive, and patients often comment on this. So all these things are very, very important. And the only way to assess this will be multi-source feedback. We can't assess them in a mini CX or an OSCE station usually. Next slide, please. So where are we now with our multi-source feedback and our experience in Australia on assessing international doctors? Since we started the program, more and more health services are using workplace-based assessment for assessing international doctors. Some of our colleges are using workplace-based assessment and gradually introducing multi-source feedback. In my own medical school in Newcastle, we realized when students graduate, they are not ready to be interns. They know a lot of medicine, but whether they are prepared to be good doctors, to work as interns, people have given us a lot of feedback. We want to prepare them for proper internship to be proper doctors from day one. So in our new MD program in year 5 next year, we are trying to introduce workplace-based assessment, including multi-source feedback. So I believe multi-source feedback is an essential part of assessment for any doctors, and certainly the program we did for international medical doctors taught us a lot of lessons which are now being adapted and adopted by the colleges, medical schools, and other organizations. We also have shown and published or work on reliability of workplace-based assessment. So if we use a certain number of multi-source feedback with mini CX and case-based discussion, we can come up with a reliable and valid assessment tool. Thank you very much. I'll stop there and we'll be happy to take questions at the end of the plenary. Thank you.
Thank you very much, Kishu. It was really, really appreciate. The next presentation is by Ole Tenkate. The slides are up, Ole.
Okay, are you advancing my slides or is this the video? Okay.
It's a set of slides.
Okay.
Yeah.
So welcome all, and this is my presentation is about an example from the Netherlands for multi-source feedback in postgraduate training. So my name is Ole Tenkate. I'm from the Center of Research and Development of Education at University Medical Center Utrecht. Next slide. So the overview is 4 points. So I'll say a little bit about why did we start multi-source feedback in postgraduate training in the Netherlands. Then I'll say something about 10 years of experience that we have with a nationally applied MSF procedure that was designed in Utrecht. And then finally have some lessons learned, and I'll end with a few items for discussion. Next slide. So why and how was multi-source feedback in postgraduate training introduced in the Netherlands. Around 2005, all Dutch postgraduate programs started using competency-based medical education. And the CanMEDS framework was chosen as the national competency framework for all those programs. And multi-source feedback procedures were strongly recommended by the National Task Force for Redesign of Postgraduate Training for all programs as part of a toolbox for formative and summative assessment. So national guidelines, in a series of guidelines, one of the national guidelines was created for multi-source feedback and published in 2010. And what actually it amounted to is that it was said that multi-source feedback was not going to be mandatory, not enforced, but basically during quality control meetings for accreditation reviews, all programs would have to justify their assessment procedures, and multi-source feedback would be one of the options that would actually be asked whether people would apply that or not. So next slide. And then the recommendation in the guidelines for multi-source feedback was that the CanMEDS framework had to be used in any procedure for multi-source feedback, including medical expert, communication collaborator, professional, manager, now called leader, scholar, and health advocate. And then proposed was that there would be 3 broad categories of respondents to be distinguished. One would be the medical colleagues, that could include attending supervisors, peer trainees, maybe medical students. And then the second category would be non-medical colleagues like nursing, physical therapists, dietitians, supporting personnel, and any other allied health. And the third category would be patients, and then multi-source feedback would be used, for instance, after a clinic visit. Next slide. So then the question was, which of those CanMEDS roles would be most suitable to include in a multi-source feedback procedure for which of these 3 categories? So for category 1, medical colleagues, actually most of the CanMEDS roles would be suitable to ask for. So maybe not health advocacy, as on the clinical ward, it might not be as visible, but actually all the other roles could be included in survey items for multi-source feedback. For the non-medical colleagues, communicator, professional manager, and collaborator would clearly be suitable. Medical expert somewhat less, and scholar and health advocate probably also less. And then the patients, the third category, there the focus should be on the communicator role and the professional role, maybe a little bit on the manager leader role in the sense of very practical aspects of organizational management. So next slide. So we then created a procedure, and that was funded by that National Task Force for Redesign of Postgraduate Training in the Netherlands. And that MSF tool that we built was a fully automated web-based tool. It was launched in 2008, stored on a Utrecht server with support from our Center of Research and Development of Education. That had the following features. So the procedure was to be initiated always by the program director, maybe asked by the trainee to start it, but the program director is the one actually who should initiate a procedure. And about 3 months before an evaluation date. So the evaluation date would be like the annual progress interview with the resident. And the program director could actually choose to start procedures for multiple residents at a time. And of course, we had those 3 categories: medical colleagues, non-medical colleagues, and patients. The CanMed based survey items for multi-source feedback were 26, 20, and 16 items for those three groups, 1, 2, and 3. And there was a lot of space for narrative feedback. And then the respondents were to be picked by the trainee. So the trainee would be asked to actually choose their own respondents for their MSF review. And these respondents would be asked to observe the trainee for a period like a week to a month ahead before they would answer their questions in the survey. And then preferably for each of these three categories, there should be 5 or 6 observers or raters. So that would be 15 to 20 in total. Next slide. So this is the flow of the web-based Utrecht MSF procedure. And the left upper corner, you see the program director would set an evaluation date and then enter also a resident's email address to start the procedure. So then the resident would receive that email, and that email would include instructions and a link to a website with a username and a password. The resident would, and was then asked to identify raters and ask for their consent to do that multi-source feedback for them. And then the resident would provide email addresses to enter into their own personal web page in the procedure. And as soon as they had done that and confirmed that, all those raters, all those identified observers would received actually an email with instructions and a link to open and fill out a questionnaire after their period of observation. So that would take some time. And what happened is all those filled out questionnaires would be aggregated into one summary report. And during that process, the resident would be able to look at the progress of the whole procedure, could not see the scores of individual raters, but could invite new raters or could send reminders to raters who did not respond yet. The program director could also view the progress, but could also open actually completed questionnaires. So the program would have access to individual scores if they would want to. And then, so that automatic and anonymous process of results resulted in that summary feedback report that with aggregated mean scores and narrative comments that was sent to the program director and to the individual resident with the intention to have that discussed in that annual progress interview of the program director with the resident. And then after that, a new cycle could start. It could start in the same year or it could start in the next year. The whole process would take about 3 months to be completed. Next slide. So here's an example of one of the images of roughly of a report. So this is a report of trainee XXX on the, and with the date of a progress interview filled out. This web page would show a report type with aggregated scores. You could see that all roles were answered by medical colleagues, pretty high scores actually, and with their standard deviations. But also the non-medical colleagues filled out a number of these things, and patients also filled out scores. And you could see that there were 5 medical colleagues, 6 non-medical colleagues, and 8 patients. And these are, of course, anonymous, but are actual data from just one sample report. Next slide. So the next slide actually shows the same report, but then only the listing of comments. That comments could be quite extensive, because if just imagine you have 15 to 20 respondents, and each of them would have like 3 comments or so. It could easily be like 50 or more comments. It could be a page or 2 pages of comments. Next slide. So that was the procedure, and I can tell you about the procedure that it was launched, as I said, in 2008. From that time on, during 10 years, we had 199 program directors actually do that once or more. And in 51 hospitals, there were 1,867 residents that were evaluated, and altogether there were 2,633 reports on those residents. There were MSF ratings done by 30,000 respondents that would include medical colleagues and non-medical colleagues and patients. Now, what happened in May 2018, the European data protection regulations came into effect, which actually led to a decision that had to be made to build or not rebuild the whole tool to comply with those new European rules. And we found that in that period of 10 years, most postgraduate programs gradually started to use commercial e-portfolios for all their trainees. And quite a number of those e-portfolios would include an MSF option. So that we actually made the decision after 10 years to actually not rebuild this program. So we have used it for 10 years, and this is just an overview of that 10 years. Next slide. We did some evaluations. So in 2012, we surveyed 130 users that were residents and program directors. And what we found generally is that people liked the procedure, found it easy to use, very informative, widely applicable, and best suitable for postgraduate year 1 to 3 trainees. 45% agreed or totally agreed that the aggregated scores were useful, but 100% agreed or totally agreed that the narrative comments are very useful. And about 1/4 agreed or totally agreed, because we asked that, whether the MSF report would be sufficient to identify poorly functioning residents. Clearly, people generally thought you would need more information than an MSF report to identify those individuals. We asked in that survey about the benefits of 4 levels of Kirkpatrick for educational interventions. And those 4 levels are reaction, that people like it; learning, that they have the impression they learned from it; did they actually change their behavior; and did that behavior change also impact patient care? And both from residents and from program directors, and I must of course admit that's only subjective impressions, but they all had the impression that it actually were effects at 4 levels of Kirkpatrick. And then the one comment that quite a number of people made is whether in that procedure a self-assessment could be included next to those 3 categories. Then there was one other study that was done recently, actually, that was by Caroline Buys, whether a neutral coach to discuss the report confidentially with the trainee before the formal progress interview with the program director, whether that was useful. And actually most of the trainees, almost all of them, actually really liked that, to be able to identify what were the pluses and minuses, to analyze the report with a psychologist, and to prepare for that progress interview. And I think Claire Tucci also mentioned that would be good to have a coach to discuss that report. Next slide. So finally, some additional thoughts that we could maybe use in the general discussion. So one question would be, should multi-source feedback be formative, or can it also be summative? The next question could be, should trainees be allowed to pick their own raters or not? then a third question could be, should self-report be considered a component of multi-source feedback or not? And then what we found is that patients are usually very positive about learners. So the question would be, should we seek ways to make them more discriminative? Well, that was actually my penultimate slide. The last slide is just references. Thank you for your attention to this presentation.
Thank you very much, Ole. And we had presentations from 3 experts from Australia, Canada, and Netherlands. And I thank all of them, including Andrew, for organizing this symposium, though they can't be here physically. And now the panel is taking questions from the audience, both the physical audience as well as from the virtual audience.
Madawa, I've got a question for Claire.
Yes,
from
please.
the online participant.
Okay.
Claire, can you share some examples of an action plan, please?
Sure. I'll give you a very concrete example. So one participant had comments from 3 different sources, from the patient and from the coworkers and from patients, that they were actually speaking too quickly, and that people had a hard time understanding what they were to do. And so there was a very clear plan that this person would take a deep breath and speak much slower, but also make sure that they close the loop on communication to make sure that what they had said was well understood. So that's one example. Other example are that charts would be incomplete. So they were asked to ensure that charts were completed. So both physicians and nurses had noted that charts were not being documented in a timely manner. So those are examples of action plans.
Thank you.
David Black from the Physicians Training Board in the UK. So I'd just like to pick at this issue which Ole just mentioned about, is this formative or summative? The first speaker said it's purely formative. The second one said it was formative, but then said that MSFs were being used to fail some people, whatever that meant. And then in Holland, we've heard that for trainees, it was being used in both roles. Certainly within the UK, where all our trainees have to do it every year, it is part of the decision-making process of whether you're going to progress. If there are serious issues raised in the MSF, we certainly would look for evidence elsewhere in the e-portfolio to see if we can triangulate it, and we would certainly look for evidence that it had been addressed one way or another, or was not a concern. So we do believe it is part of a summative process of progressing training, and certainly with the emphasis which has been talked about of, the importance of soft skills and generic competencies. Surely we do have to use whatever is the best measure we have to decide if people can progress or otherwise.
Thank you. Andre, any comments? Ole?
Yes, so I think I agree with you. Actually, if you really take that seriously, then it should be important. And if it's not important, you can say, well, it is formative. The one thing that struck us in the procedure that we used is that everybody agreed that the narrative comments were so important, and not everybody agreed that the aggregated scores were so important. So if you would define a summative instrument as an instrument that would say so many people have to score exactly at that level, and if people score that, it would have summative consequences, I would probably not agree. But if you would say we don't use those narrative comments at all because we don't use that in any procedure to evaluate the learner, then you're missing out important information. So I think it should inform the decisions about progress for individuals. If you don't use that at all, you can just even wonder why you're actually doing multi-source feedback. But I wonder what Claire would say about that too.
So I would tend, the answer is it depends. In our case, the multi-source feedback is used for practicing physician, and it should not be used in and of itself as a tool for summative feedback. I think that if it's being used in a program of assessment, it's a piece of information that can inform, and if everything triangulates and shows that there are difficulties, it can be used for summative purposes. But we've shown very clearly with our validity evidence to use this tool on its own for a summative decision would probably be harmful, in that I don't think it's sufficiently robust to do so for that purpose. In the setting of education, in the setting of residency, if it's being used as part of a program of assessment and it's one piece of information, I think it's a very useful piece of information.
I think the key part, if I may jump in, of the question is part of the process which was raised and which everybody touched upon. I think there's research, in fact, done in the Netherlands, Van Moonen, I believe, was the author, that showed that when combining, MSF with other in-practice types of assessments in a fairly high stakes, I tend to view these things at low stakes, high stakes, not formative, summative, that it is actually quite informative, that composite or combination of tools. In terms of the discrimination aspect, and Claire alluded to this in one of her slides, and actually Ole alluded to it also, I think there's mounting evidence and research. There's a couple of papers that have been published in the last year or two that are showing that different types of items for this particular form of assessment seem to be much more beneficial in terms of the quantitative side of all of this, if you wish, or the test item side of all of this, whether that be ranking or paired comparisons and so forth. So I do think that's an avenue of research that's worthy of considering in this particular arena.
Thank you.
Thank you. Here. Again, we use the workplace-based assessment as a programmatic assessment. We use mini-CX, multi-source feedback, case-based discussion, and in-training assessment. And again, on its own, it may not be a summative tool, but we put all these assessment tools together, we could come to a definite assessment. And again, you mentioned the research. I think certainly we did a reliability study on this with mini-CX and CBDs and in-training assessment, and we found it to be reliable. I think the others were included Case and Joyce Moonen, and I think Brian Jolie, I just saw him in the audience, he's there too. So we have shown, we put all these things in a toolbox. This is a reliable tool. Maybe Brian on side may want to make comments too.
Thank you.
Brian Jolie.
Is Brian here? Yeah. Is Brian here to make a comment on that? Yeah, could you? Okay. So he agrees with you. Okay, Prof. Harden.
Okay.
Ronald Harden, thanks first of all for some great presentations. Just a quick question of Claire. I noticed you didn't use, as part of your input, students. We know all doctors are role models, and students can form very good opinions of the role models and contribute valuable to their development. I just wondered why you didn't use students. I noticed Ollie did use students and trainees. I just wondered why you excluded students.
Medical
the physician colleagues, this MSF was specifically designed for physicians in practice, not necessarily clinician teachers. So most of the physicians that we did the pilot with would be community physicians and not have very many students around them. However, we're looking at developing one specific for clinical teachers, where students and residents would be a key group actually that would answer the survey. So it all depends on which part of the practice spectrum you're on.
Thank you. Any other questions from online participants?
Hello, yeah. So, Dr. Arshad from IMU, but I'm from Pakistan. All these three studies are from the developed world, Australia, Canada, and Holland. So I'm just thinking this workplace-based assessment involving the patient particularly and non-medical staff, will it be applicable to the third world or the developing world? Because the spectrum of the patients are quite different. You need for this to be constructive, this type of assessment, you need a high level of education. Literacy rate should be high. The patients, if you are considering the patient opinion, that has to be considered in mind. Thank you.
Any comments on cultural differences?
I can probably answer that from my own practice. I've actually done an MSF, and my practice is with refugees. So the patients, obviously, sometimes you need, in my case, translators to help with the being able to answer the questions. But also you need to make sure that the questions are designed, and our questions are designed to be at a very basic level. They're meant to be designed at between grade 3 and grade 6 ability to read for the patient surveys. So we do not expect our patients to be highly educated. We expect the questions to be simple and to be straightforward. Their ability to be able to respond to questions, we had nurses in our clinic that were able to help them if they needed help with answering the questions from a writing perspective. So I think there are ways to do this in the developing world. I think you need to have educationalists that work with you, that understand your public, and that understand the level at which and the type of questions that you can ask that will be answered in a sufficient way, and in a way that's going to be helpful to the physician to move forward with quality improvement.
Kitchu here. I think I've done some workshops in developing countries on workplace-based assessment. The feedback I get from those workshops would be, this is a very valuable way of doing it. Our non-medical colleagues, non-doctor colleagues are very educated. They can spot a good doctor and a bad doctor on global assessment. So while the patients may be slightly different, I believe non-medical colleagues can comment on the doctor's performance.
I'd like to add, but
Who would like to add? Yep. Thank you. So next question. Yep.
Hi, I'm Nurun Hussein. I work in Qatar. I'm just wondering, you mentioned about multi-source feedback from doctors. Have you considered getting feedback from different specialties? Especially our juniors, when they're on call, sometimes you get informal feedback, and I think it would be useful to get sort of opinion from other doctors about our junior colleagues.
Any out of the
Yes, we do. I think certainly the colleagues can be sometimes very critical about their colleagues, and we also found out the best feedback we got from sometimes would be from non-medical people, like the ward clerk. The receptionist will tell you whether the doctor will come when you're calling the doctor to come and see a patient who is who needs a doctor straight away. So, yeah, everybody can spot a good doctor and a not so good doctor. So I think this is a very good tool. That's why it's called 360-degree assessment. You're asking for people working above them, below them, and around them.
I met doctors from other specialties. So often the multi-source feedback look within your own specialty. I just wonder whether there's inter-specialty feedback.
Okay, the trouble or challenge could be, you need to see the doctor on a longitudinal basis. If you see them just for one emergency, that may give you a slightly biased view either way. So I think if you want to give somebody a 360-degree assessment or multi-source feedback, I would have thought they should have seen them for a length of time, not just one instance. others may have different view.
Thank you. I think we can move on to some of the online questions.
Yes, I've got one question from online, from Shazia. Will you add self-assessment to trainee as part of workplace-based assessment?
Can you repeat the question?
Okay,
I suppose it's for me.
Sure, no problem. Will you add self-assessment to trainee as part of workplace-based assessment?
Self-assessment?
Yes.
Okay, yeah, we use self-assessment, but we didn't take them as a summative assessment because some of the trainees thought if they rate them very, very high themselves, 5 out of 5, and then the other people rated them 2 out of 5, they thought we take the average and pass them. But certainly it's a good tool if they can self-reflect and rate themselves. And the trouble is somebody is rating themselves all 5 out of 5, and then other people rate them 2 or 1 out of 5. There are some insight issues, and we were able to pick that too. Yeah, I think we have used that, and certainly it is used to see how they reflect on their performance. Thank you.
Okay. Yes, please.
Yes, hi. My name is Anna Buszewski. I'm from the University of Ottawa. Hi, Claire. Thank you for all the speakers for a wonderful presentation. I'm looking at the 360 from sort of, I guess, my lens where I'm Director of Professionalism, so I have to deal with remediation. And I think the 360 can really help with the insight, the issue of insight. You're getting a perspective that sort of gives you a juxtaposition for a person to perhaps understand where the problems are. But as Dr. Tenkate said in his study, 27% felt, I guess it was probably the program directors, felt that this identified poor performance. So the question is, how do you get around the bias? Because in most 360s, as I understand, you actually choose who's going to fill out the form. So can you get around that and I guess get an unbiased view, or is it the numbers perhaps? Like if you have 20, Claire, you mentioned 25 patients, so I presume that gives you a broad base, but can you really get that with, let's say, 5? Thank you.
So
yes.
I'll start, Anna. Thank you for your question. There's actually some work that's been done looking at whether you choose the respondents or whether you let them self-select. And we were quite amazed when we looked at our data to see that all of ours were self-selected. They could select the physicians and the coworkers themselves at the honesty of the comments. The comments are very honest and not necessarily, they can be very critical, although always couched in fairly good language, in constructive language. So I think that bias is certainly something that needs to be further studied, although there's controversy in the literature as to whether or not it helps or not. I think if you have a broader base, it helps. And one of the things we're trying to institute, we're working with one center, is that there should probably be certain people that are part of the MCC3s or of the 360. So if you have a clinic director, if you have certain people that may give an opinion that will be less biased, that you include them. So that's one way of looking at it as well. But I was quite amazed at the quality of especially the narrative comments.
Thank you, Claire.
Thank you.
Any more questions from the audience here or from online forum? Yes, please. One question from the online forum.
Sorry, there's a question from Ong. Could you provide us with best samples or examples for survey questions, e.g. article?
I'm sorry, I didn't
Come
quite
again, please.
understand
Yeah.
the question.
I didn't get the question
All right,
either.
let me repeat again. Could you provide us with best samples or examples for survey questions?
Okay, they want some example questions that you have included in multi-source feedback, I think.
Sure. I don't have any in front of me. I don't have the surveys in front of me right now, but from the patient's perspective, it would be related to communication skills. So this physician communicated the information in sufficient detail would be an example. Kishu, do you have your survey in front of you?
I have a question right in front of me.
There you go.
Okay.
Go for it.
Okay. We used different questions for medical colleagues and different questions for non-medical colleagues because people see things slightly differently when you're a medical and non-medical colleague, and they are mutually beneficial too. So the questions to the medical colleague would be: does the doctor communicate well with patients, reaches the correct diagnosis in a timely manner, refers patients appropriately, provide appropriate information to colleagues to provide follow-up patient care, because transfer of care is very important, accept responsibility for care of ongoing issues, provides information in a timely manner about patients when needed, takes action when urgent intervention is required, takes responsibility for actions and decisions, demonstrates appropriate clinical judgment, maintains patient confidentiality, works well with colleagues, speaks respectfully of colleagues in conversation with patients and co-workers, documents care appropriately, is willing to take responsibility for error, contribute to administrative practices, writes prescriptions and orders clearly, committed to current advances in medical education. So we just trim the questionnaire. This question, the medical colleagues now will have 17 questions to answer. You want the non-medical?
Few examples, maybe.
Again, the non-medical colleagues, again, communication with patients. I think is available to patients when needed, is respectful and receptive to co-workers, confidentiality, speaking carefully of colleagues in conversations, respects my professional knowledge, because I think that's something which we didn't have in the other thing, because we need to respect our colleagues, is proficient in English, because we are speaking English-speaking country, treats patients with respect, appropriate knowledge and skills to provide proper patient care, treats me with respect, manages stressful situations, collaboration with colleagues, is willing to take responsibility, writes prescriptions and orders clearly, supports good patient care. Yeah, I think those are the main, those are the questions for non-medical colleagues. They're slightly different because different people see different things.
Kishu, have you got a question?
I was just going to add a corollary comment, if that's okay.
Yeah, sure.
Yeah, with many of the analyses that Claire referred to that we're undertaking right now, some of them are qualitative, some of them are quantitative, and now we're in the realm of machine learning, which is really opening up a lot of possibilities. Yeah. We're really learning a lot about the items and the themes that we've included in our surveys. We actually believe that, as we evolve with this program, that we'll arrive at a point where we'll have a really clear indication of which items give us the most signal, essentially, or the most bang for our buck. And some of the items, may not be that useful. We're certainly not there at this point. We've only done some pilot projects, but I'm personally very encouraged that we'll get to the point where we'll be able to identify those key items that are really, really important in terms of correlating with the feedback for one thing, which is another thing we're looking at, and that's important.
Okay, thank you, Andre. Any other questions from online? Oh, yeah, okay, sorry. Yes, please.
Hi, I'm from Australia. I work in mainly more in a postgrad training situation. I was just wondering, like, how many respondents would you require to actually make your multi-source feedback actually valid?
Okay. It's about psychometrics, I think. How many responses are needed to make a credible decision? That's what she asked.
It was the last word reliable? Sorry, I couldn't hear. It was distorting. Oh. I'll sort of answer your question. What we've found, and this goes back to Claire's point about we're not at the point where we can use this as a standalone, necessarily a standalone instrument, but maybe part as a process for I'm talking about summative type of decision here. We have found when we look at the composite of comments and ratings from patients, physician colleagues, physician non-colleagues, we found that the reliability, generalizability in this particular instance, of that combination is actually quite acceptable. It would be in the range of 0.75 or something like that, something you'd expect with a performance type of assessment. In terms of what you might see in the literature, you might see things like 8, 8.25 or something along those lines in terms of physician colleagues, non-colleagues, and patients. There's no golden rule. I think a lot of this is dependent on the process that you've implemented, on the items you have, et cetera, et cetera, et cetera. I think it does beg the question, though, of doing a good program evaluation and looking at what works and what might not work with your particular program. I'm sure everybody that's spoken, the three speakers, their programs are quite unique in that way, and they might want to add to that also.
Thanks, Andre. Okay, reliability. The evidence, as far as I know, would be something like 18 responses from people. But again, the question then is 18 doable? In our program, over a period of 6 months, we did 12 mini CXs, 5 case-based discussion, and 2 sets of 6 each multi-source feedback. And that gives a reliability, which is published in the Medical Journal of Australia. So you may want to look it up. You're from Australia. Thank you.
Thank you. Okay. May I ask Andre to summarize everything, because there's no more questions online as well as from the audience itself?
I guess I just want to start off by thanking our 3 speakers and also thanking all of the members in the audience and maybe virtually that posed the questions. You probably got a sense that we're all learning a lot as we move forward with these various programs and that we're all facing similar issues. So my hope is that we can continue these conversations and learn from each other, which is certainly something we've done over the past year or so since we've started seriously with this program. I'm not sure if my presenters want to add any final thoughts or words also.
Kichu, I think it's been challenging to coordinate this presentation from different time zones, different countries. We're all away, and I think the team within this presenting team did really well, and the people in KL did extremely good job to pulling it together. So I was anxious when I started, but I'm glad it went really, really well.
Thank you. Yes.
Thank you very much. Thank you, Andre, Claire, Kishu, and Ole for contributing for this valuable symposium. Though they could not be here as presenters, I think you gain a lot about multi-source feedback and its current position as well as the future directions through this discussion. And I would like to thank all 4 presenters, experts, on behalf of the IMI organizing committee. Thank you very much. Thanks.
Thank you.
Thank you.
Thank you.
Thank you.
Yeah.
Good day, good night, good afternoon.
Okay.
Good day.